and to be fair, it's not just Baptist, but it's all of the hospitals. It's
It's
just the way that certain
these
things are run at.
larger organizations. Yeah, these
Yeah, it's
larger
just
hospital
larger
systems.
organizations. You get lost, the individual gets lost in the mix, and the patient is just a revenue number.
Yep.
So it's funny that we're starting with this stuff and ending this, our intro convo with this because our topic today is all kinds of fun for me.
Yeah, this was an article that you brought to my attention about the
Yeah,
Aetna. I'm going to post that in the chat for everybody as well. And for those of you that might just be joining us, appreciate you joining in with us today. My name is Ray Walters. I'm with EPICompliance. We'll be your host for today's session. I'm joined here by my co-host, Jose Delgado Jr. Has 20 plus years of experience in healthcare consulting, currently owns a mental telehealth clinic, also works for a healthcare consulting firm. So we've been doing these webinars since October of 2023. We have a pretty extensive catalog of topics that we've covered. If you haven't already, please like and subscribe to our YouTube channel. I posted a link in the chat. But yes, today this is a topic that Jose brought up, and I'm posting the article in chat now.
perfect. So
Um,
I want to preface this with a couple of things. One, why did I pick it? And two, there's some information that we need to go over, some basic terms and definitions, right? So let's start with the easy one. I wanted to pick it because this thing is juicy to me.
oh
And
yeah,
it's juicy because there's a lot of legal interplay. There's a lot of, I can sit back, just grab a tub of popcorn and be like, I see why the both of you are wrong, and the both of you are kind of right. But it's going to depend on
right.
what information is considered more important, right? So this is where the story and the realities of life and the frustrations of a normal person can really change things. And this is a situation where a law was written in a certain type of way, and I don't think the writers intended it for it to be used this way, but it's going to be better for the overall conversation and goal. So we're talking about the No Surprises Act. A lot of people have heard of it. Not many people know what's in it, much like everything in healthcare legally, but let's break it down a little bit, right? So No Surprises Act, as the name implies, was designed to stop the opacity with which the healthcare industry bills its clients, because patients are clients, whether they're paying, whether they have a third party that's paying. When you sit down with a practice, you're looking at, okay, I've got a cash, if they have numbers, if they actually have a fee schedule, which most practices don't because they let their billing companies handle it, because of the complexity. But basically, what ends up happening is you have your cash price, if you have prices at all, you have your cash price, you have your Medicare price, and then each individual insurance company you have a fee schedule for. Now, when you sign up and you credential with an insurance company, they and you negotiate a contract.
Hmm.
And I'm going to go ahead and just, as someone that's been doing this for quite some time, this truly annoys me. How would you buy a car, Ray, or buy a house, and the price that you're paying is given to you after you sign on the dotted line that yes, you're gonna buy?
Absolutely not. I'm not taking that
Somehow
risk.
that's acceptable in the healthcare industry. If you want to be part of an insurance company, you got to bend over backwards, pray that you find someone intelligent at the insurance company that'll pick up the phone and send you a fee schedule. Once you sign on the contract that you've been credentialed with the insurance company, then you have the opportunity to try to negotiate. But a lot of insurances have been playing hardball over the last 10 years, closer to 15, but really, really hard last 10, and saying, hey, practice, you either take my price, pound sand. We just won't send you patients. They had control 10, 15 years ago. Now patients are figuring out that less and less is getting covered, it's getting more and more expensive, and they're paying us providers less and less. So why do we want to play at all? Right. So
Yeah.
No Surprises comes into play because This should be a very simple transaction. Just like when I go to get my oil changed on my car, just like when I'm talking to a plumber or an electrician, just like when I'm buying anything at the grocery store. I should be able to find out how much the service is going to cost me. It's very, very simple. The No Surprises Act forces everyone to have an actual fee schedule and for it to be readily available for the patients. Doesn't mean you have to have a gaudy board like a Tire Kingdom or something right above your window, your front desk window, but
Yeah.
you need to have it readily available for patients. I have no problems with that at all. What this also does is that it also forces the insurances have to comply. It forces the hospitals to have to comply. Good luck calling a hospital and finding out what an MRI costs because most people won't be able to tell you because there's a whole process. Okay, do you have insurance? Okay, let me verify your insurance. Let me see what your deductible is. What's your copay? So the overall price would be this, the copay would be this. And that's if they were quick and able
Yeah.
to get on the ball
Too
fast,
much of
right?
a process
Yeah,
for
yeah.
them.
So now let's get into the details of this case. Aetna is suing a physician group for fraud, and I'm going to put that in quotations, and they are going through the No Surprises Act IDR process, which is the independent review, right? Okay. Lots of words to basically say this. Maury Bean, Radiology Partners and Maury Bean and Brooks. Okay. Radiology Partners is basically a private equity out of Texas, I believe. And they have imaging centers all over different states. Specifically for this case, they're talking about Florida,
Florida. Hmm.
Northeast Florida.
And this
And what
happened
they
in what,
do,
2022, correct? In
yes,
terms
in
of,
July
yeah.
20, well, parts of this happened in 2022, but the lawsuit was filed just 2 weeks ago on the 23rd of December of
Right.
24.
Right.
Right.
Okay.
So
Yeah.
basically, what happens is this: when a private equity is going to buy a practice, there are certain things that are valuable to the private equity, and there are certain things that are not. One thing that is valuable is the amount of revenue. Duh. Another thing when they're buying in healthcare is how long you've had your contracts with your insurance agents, insurance companies. So if you've been credentialed with, for example, Blue Cross or Aetna or Cigna, and you've had it since 2007, that contract and that fee schedule is worth so much more than if you got credentialed in 2018, 2019, or even 2014, 2012, because the contracts are
Grandfather
very,
clause.
very different. Yeah, they're grandfathered. So the
Yeah.
pricing is all over the place. So Aetna will go and say, hey, for this service, I'll pay you not just a flat fees number. What they'll do is they'll say Medicare plus 10%, or 115% of Medicare, or 85% of Medicare. So then you have to go and splice out what Medicare is paying. It's a whole
Hmm.
it's a whole treasure map. You're deciphering all of this stuff if you took the time to even look at it to begin with. So what are they doing? Basically, what Aetna is alleging is that this radiology group was conducting the services. They never alleged that the services were never conducted, but that they were conducted, that they were medically necessary. The trick is in how they were billing. They were billing under the preferred contract from the preferred partner of the area. Now, is that legal? Not really.
Hmm.
You're kind of gaming the system because each individual, because the way if they had set it up and made it to where Maury Bean and Brooks was the umbrella corporation for all the parent corp for all of the other corporations, they could have done it. But Radiology Partners does not have a contract with the individual insurance companies. So Aetna said, no, 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 you can't do that. We're booting you. So then Radiology Partners picked another radiology company with a contract and went that way. So they were always trying to bill under contract with a credentialed partner of theirs just to make sure that they could, one, serve the patients, and two, get paid Aetna in network. Aetna caught onto it, booted everybody. They're all out of network. Cool. So then Radiology partners, Maury Bean and Brooks, decide, hey, we're going to go ahead and bill out of network because I don't have a choice anymore. And then they got mad for billing out of network. Wait a minute. You can't get mad for billing in network and then get mad for billing out of network.
One or the
That's
other.
not how this stuff works. That's just not how it
No,
works.
I
If
agree.
I can't bill in network and I can't bill out of network, how would you like for me to capture my money?
Right.
Well, the only thing that's left is to go after
Cash.
the patient and say, hey, patient, pay me because your insurance won't. Now, this is where Radiology Partners sues Aetna under no surprises because they are saying, hey, this is medically necessary. We actually did it. Whether we were in network or out of network, you got to pay one way or the other, and you're not paying a red cent. And this is a product, this is a service that's in your product that your patients are supposed to be able to have access to. So this is a scenario where company A is in trouble, and company B is in trouble too. And it's just a matter of who's going to win this kind of thing. In a normal realm, a small practice would not, even a normal size practice, even a hospital, would
Can't
have a
compete.
hard time trying to justify a legal case because they just don't have the funds and lawyers to do so. But when you have a private equity that they're coming from the finance industry and there's two things they know, lawyers and money, they're coming and they're going to spend the money. What's interesting to me and why I want to keep an eye on this one is if Aetna loses this case for not paying contracted rates, we have a very, very, very interesting precedent because now practices can use the No Surprises Act as a way to sue these insurance companies for not paying.
Good point.
So
Kind
you
of.
can sue Humana, you can sue Cigna, you can sue Aetna because they're paying you pennies on the dollar. They're not even paying you the contracted rate, but you're contracted with them and you got to follow all these BS rules. You got to do the prior auth. You got to get the script from the primary so that way you can bill because if not, it's not medically necessary. And all this nonsense, you do every single jump, every single front flip, back flip, jumping jack, burpee, and they still say, here's 10 cents on the dollar. That's not how this game's supposed to work. Everybody's got to make money. Pigs get fat, hogs get slaughtered, right? So Etna, I guess it's your turn. That's the way I look at it.
Well, if they do end up losing, then that's certainly,
If they
that's
end up
obvious.
losing,
They're
if they
gonna,
end up losing, well, actually, let me take this back. No matter the outcome, I do expect for a wave between this and the new HIPAA regulations that we're going to be talking about next week with Dr. Delgado. I
Mhm,
do foresee that a lot of contracts are going to have new clauses in there and new stipulations because the reality of the matter is that this is going to change things.
sure.
Because
Well, I
I
foresee
mean,
that if Aetna loses, that's
Aetna
certainly going to be more
loses,
lawsuits. We're going to see
it'll be a
that.
class action. It'll be a
Yeah.
class action against every insurance company.
Yep.
Every single one. And if you're one of these Medicare Advantage companies that are playing around with these definitions of what a quality contract is, but you're not following through the letter of the law, but you're reinterpreting the numbers that you and the definitions and the measures that you're demanding, you're gonna have a problem. You're gonna have a problem. And what's really, really interesting is that apparently this isn't the first time Radiology Partners and Maury Bean and Brooks goes through the No Surprises Act and recovers money. They
Oh,
have a 98% win rate
oh
through
yeah,
the
that's
No
right.
Surprises Act arbitration. You know, people joke.
It's
I
pretty wild.
remember reading a paper and say and they were literally saying anyone that says north of 95% is just guessing. It's 98%. It's 99%. You don't want to say 100%, but you don't really have a number. You have a plurality, maybe even a majority, but you don't have a full-on number. Not for them to put a 90% win rate and for them to not even put in the
Shoving it
complaint that
in
they
their
win
face.
these on the regular, this is wild.
Yeah.
Wow. And in the complaint, they literally radiology partners literally puts the overwhelmingly clear trend indicates neutral third parties applying federal law conclude insurance companies uniformly fail to fairly compensate providers who support patient care. That is wild.
Yeah.
That is, I love these kinds of sentences. I want to meet the lawyers. I do. I do because I truly enjoy reading sassy legal opinions because they're hilarious. They're for me, they're Mark Twain. Like I crack up. The way that people can use the language to insult in such a way that the other person doesn't know that they're being slapped. It's just it entertains it makes me so giddy like a little schoolgirl. So I mean this one's pretty cut and dry because it's still brand new. The
I know.
lawsuit.
Is there anything new? I didn't see anything in the article when I guess when they're looking to because it's still going through the process, obviously.
Well, so remember that the IDR process for the No Surprises Act is relatively new, and they haven't really
Hasn't
gotten
been
the
enough
process like
yeah.
super down pat. But this will probably move pretty quickly, and if it goes to a judge and a court with the sentiment that's going on right now, Aetna does not want this in a court with a jury. And it doesn't want this in a court and a jury. Now, the only thing that really hurts this company's case, Radiology Partners case, is that they can't be argued to be a mom and pop. But if this was little guy against evil insurance giant with the sentiment that's going on right now, you would not find a jury that's going to find against Radiology Partners.
No, not at all. It's all gonna be
It's
against
just
Aetna.
never gonna happen. Like they're just gonna be like, "Oh, Aetna? Yeah, my cousin had Aetna and blah de blah de blah de blah." You know what I mean?
They're
Like
going
it's
down
just gonna
at
get
that point.
it's just gonna be. I don't care what these people got to say. It's done. I'm gonna pick.
It kind of
I'm
makes
gonna.
you it makes you
Huh?
think too, since this is all done through through the No Surprises Act, it's if like I said, if Aetna ends up losing, will
This opens up.
somebody look
Why?
to try to reform the Surprise Act or
No, I mean the no surprise life insurance company is supposed to be paying according to Wyoming. Yeah, Tracy, this one will be interesting. Yeah, I mean, just play back the beginning later. I kind of went over some of the basic processes, but the basic concept of this, but yeah, um, this will just be a situation where legislators are not going to come back and revisit this unless it bites them in the keister. If it bites Medicare or Medicaid in the butt, then yes. But because Medicare sets the price standard for services in the US, which ding, 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 everybody, we are a mix of a social safety net system and capitalism. So we get the worst of both, not necessarily the best of both. So we have the bureaucracy and we have the price controls. So we've got bigger problems with CMS and HHS with how they're paying. Yeah, oh yeah. Tracy, there's no rhyme or reason. I spent a year and a half with our practice trying to decide, hey, why are these insurances paying the same thing? Could have been same data service, same provider, same CPT code, and they just pay a different
it's a
amount.
different
Same
amount each
insurance
time.
product for the patient. Same insurance product for the patient. They just pay a different amount. Medicare is the only one that pays on a consistent basis the same price. All of the other insurance companies throw a dart at the wall. There's just no rhyme or reason for why they pay one thing. They don't pay another thing. They
Is
pay
it based off
partially
volume
here.
or
Huh?
is it truly just random?
I genuinely don't think that anybody really knows. I mean,
Hmm.
it's a grab bag. When I sit down and talk to well, Tracy, if you're saying that you don't have issues most of the time, remember that you're a Cairo, you don't get many insurances that you get to play with. But when you and I would be shocked by you saying that. I would really take a look at the break it down, see if you can pull up see if you can pull up your EOBs from last year because now we're in January, so you should have access to them all, your explanation of benefits, and see if it's actually paying out. Oh, yeah, yeah, Jessica. They're going to say it's always in the formulary, but that formulary doesn't exist. Because they could, if they say it's in the formulary, right? And I've done this before. I did this a couple of times. Insurance company, when you call, even if they have a specific provider relations section, which most companies don't anymore, I go and say, "Hey, I'm working with a provider's office. I need X information." They will tell you, "Hey, it's in your formulary." Cool. Well, I have you on the phone. You made me verify all this information. Can't you just send me the formulary that you have on file so I can ask questions about it? No. You go find it, you figure it out, and then once you have the fun question of, well, why is this happening versus that, you will not find anybody to talk to. I don't know of anybody that's found consistent people to speak to about these kinds of issues because they just don't, they're not the ones that pick up the phones. The formularies, the actuaries, the underwriters, they don't pick up the phone. All this stuff is done electronically and automatically. Good luck.
You just gotta deal with it.
I mean, if somebody does have a consistent method for finding this stuff, I want them to tell me so I can do better. I want to know. So that way we can tell everybody.
Gracie said they mailed them mailed the formulary out if I had to get them.
No, they always mail the formulary, but the trick is most of the time they don't even follow their own formulary.
Hmm.
That's the thing that Jessica and I were saying. They say that it's in the formulary, but are they actually going to follow what's in the formulary? Because they don't explain how that mathematics makes sense. They give you the formula. If you can find the formula, they don't explain how A is attributed to 15 different metrics. And at any point in time, they can change that any of the metrics. It's just it shouldn't be this hard. It shouldn't be this hard.
It's definitely I've learned a lot through this episode
I mean, it
on
should
how
be
to
very, very simple. I should know as
how much
a
how much you're
manager.
getting paid, you know?
Well, I should know as a manager of my practice how much it costs me
Hmm.
and how much I'm getting paid. Because I need to know if are we even profitable.
Yeah.
So if it costs me $60 for an office visit, for a 15-minute office visit, and the insurances are paying me 30, is it even worth taking it? No, because I have to go after the patient for the 30 bucks. Now, here's the worst part about this whole scenario to make it very, very simple. If I go and charge 60, the insurance pays me 30, but the patient has a deductible or a copay that's so high that I'm getting more money from them from Jump Street, why does anybody have the insurance company? You have deductibles. I do not see deductibles on a regular basis under $5,000. Ray, you
Cash
have a
pay
child. You
cash
have
is
a
king.
child and you're you, right? You're two people. How hard is it for you to hit $5,000 in a year?
What on it on
You have some there at 500. Now, Tracy, is that health insurance or car insurance? Because car insurance is a little bit different. Health, okay. Then they're paying a massive amount. If remember, because the way the insurance works, and this is every insurance, if you have a very high deductible, you have a very low premium.
hmm.
If a very high premium, you get a very low deductible. That's how they measure, that's how they control spending. Remember, your max out of pocket is usually the same amount as your deductible. So if I'm a family of four and I have a $5,000 deductible, which I see every day here in Florida, every day from every insurance company, $5,000 is the deductible. $5,000 is the max out of pocket. That means that on top of the premium, I need to have $10,000, and it resets every January. This is why when you have a practice
Too much, man.
that does procedures, their busy time is October, November, December, because they're as close as meeting the deductible as they're going to get. Shoot, my buddy, actually a guy that you and I both know, he spent most of December going to the dentist, getting different things done
Yeah,
because
the
he and his
insurance.
family had already met the deductible. So he said, "Screw it, we're doing it."
Might as
I've got
well.
another buddy. I've got another buddy. He's super excited. Why? Because he's got a thing in his shoulder he needs to get fixed. But he didn't want to pay the max out of the deductible and then move all the way up into that max out of pocket. But his wife is pregnant. They're due this year. So he's going to pay the deductible anyways. He's just going to wait for the pregnancy to take up the deductible, then get his surgery for as cheap as possible. Change insurance. I mean,
Get
Tracy,
a,
you'd be shocked. Remember that it's not just having an insurance, right? It's also having the access to the network. The more specialists I have, the more drugs that I'm on, I also need to take that into account, right? And this is something that Medicare Advantage patients really get hosed on because they get sold a product that is supposed to be better, and it may be better, but their providers aren't on the network, which then leads to a whole bag of other problems. Or the drugs that they use that they use every day are not covered in the formulary. So then you have another problem entirely, right? So
Mhm.
there's a I hate to say, but changing health insurance is not as easy as changing my car insurance or changing my renter's insurance or my homeowner's insurance. Like that stuff is, I hate to say it, but relatively simple. It doesn't spider in as many ways as it does with health insurance. So with especially if you're of a certain age where you're on meds and you're seeing a specialist every 90 days, you got to make sure that everything is there. Some changed plan that were because their wife was pregnant and due in April. He ended up paying less the following year. Yeah, I mean, it just it and then I wonder if it's gonna go back up, Tracy, that baby counts as another individual on the plan. Because during the pregnancy, that person's not on there premium wise.
Oh, it's gonna go up.
You know what I mean? Like, so I mean, this game that the insurances play is wild. And there's a lot of times, and this is what the news and certain congressmen have been referring to as ghost networks or narrow networks. What that means is these insurance companies are not updating their roles. So they may say that in a certain area they have X amount or they have a certain amount of specialists credentialed with their insurance company. One, that doesn't mean that those providers are taking new patients. Two, there's no way that the insurance is keeping up with the fact that some of these companies are defunct, retired, or they've merged with other companies and let the contract just sit there because they're not going out, they're not doing a mailer, they're not interacting with the community. They're just, I'm the insurance company, I do what I want.
And they're not
I mean,
transparent.
I'll name drop, I'm fine with it. I'm sure it'll cause me trouble down the road. Blue Cross is in our backyard. Blue Cross of Florida is in our backyard, Ray.
Yep.
They used to have an entire provider department, and those people would go out and, hey, how can we help you? Hey, let's make sure that everything is nice and smooth from, the patient care aspect to billing and all of that. Those haven't existed since before COVID. They gone.
It's done now.
Yeah. Now I got to deal with Blue Cross like I do with Humana. So
Well,
I mean,
what was it? The webinar we did sometime between October and November with Blue Cross and reaching a deal with Baptist Health.
yeah. So Baptist played the game of credentialing, right? And they were like, hey, they had enough lives to renegotiate, right? Remember that
Yep.
this is all
Yep.
about size. If I'm a one doc, two doc shop where my entire patient population is 5,000 patients, no insurance is going to negotiate with you. Which is why you see these MSOs, these physician-owned groups, these private equity groups, their whole goal is to get to that 10 to 20, 50, 100,000 lives that they affect. So this way they have flexibility because if I'm affecting 100,000 lives or I have 20,000 lives that are active, that means that I have 5,000 Medicare lives. I have 5,000 Blue Cross lives. At 5,000 lives, I have weight. I can negotiate some.
You had some leverage.
You have leverage, right? Like, I mean, if you're a one doc shop, two doc shop, the insurances are saying you need to kiss our feet for even taking you on. That's not the way that this thing works now. Patients are getting smarter. They're realizing things aren't covered. They're realizing that I'm sold a bill of goods as in regards to this network. Yeah, I've got a specialist on the network, but I don't have access to care. I had a provider before I got this insurance, but he doesn't take that insurance. So now I don't have a provider. So I didn't get to keep my doctor, but I got a new insurance. It's gotten to the point to where there used to be a market difference between an HMO and a PPO. And the last 4 years especially, I've literally seen PPOs that are just HMOs with a code on.
Faking it.
Yeah, with how narrow the networks are, with the requirement all the time of a prior authorization. And I'm not saying that prior authorizations are necessarily a bad thing. They're just overused now. They're overused when it comes to imaging. They're overused when it comes to medication. They're overused when it comes to going to see specialists.
Hmm.
I see this all the time where it's like, hey, all right, I have a broken ankle. Actually, I know a patient that I'm helping them out navigate the system. They have a broken wrist. They went to the ER. For whatever reason, they waited to go to ortho. They tried to go to ortho. Ortho said, no, you got to go to primary care or go back to the ER to get the script changed so that way I can see you. Then they go from there to yeah, oh yeah. So then they go there to the ortho. So then the ortho can finally start doing the work. And I'm like, orthopedic surgeon's an MD or a DC, usually an MD.
Yeah.
Why are we having this problem? Why is this? Why do we
Well, the
have to
fact
go
that they were
through
trying to send
this?
them back to primary care, that doesn't, what sense does that
Patient's
make?
also a Blue Cross in Northeast Florida. It used to not be like this, man. It used to not be like this. And I
It's like
get
by
it.
that time you're going to have complications and
Oh, yeah, they're gonna have to re-break her wrist.
yeah, yeah.
It's because it was probably a
Healed.
low-level fracture,
Yeah.
but she's had it for so long and she's got limited mobility and she's got shooting pains when her hand moves a certain way. I think they're gonna have to break this thing, to reset it. That's wild to me. Like the whole thing is just wild nowadays. But to bring it back to the topic for today, the topic for today is very, very simple. Keep an eye out. If you don't have a fee schedule, figure it out. If you have a fee schedule, have it ready. I know that we should probably talk about ADA compliance because it causes problems for people's websites nowadays. Um, but you really should have something that and train your staff on, hey, what is that price? And make sure that it's accurate because part of the No Surprises Act is about the accuracy of the estimate, right?
Mhm.
So if I say, hey, it's around $500 and the patient gets a bill for 900, you have a problem, right? If the patient says, if you say $500, patient gets a bill for 600 and they have insurance, they're gonna be like, well, why didn't the insurance pay? Then you can get to have the fun game of, are they in, are you're not in network, or they denied the coverage, and thus it's patient responsibility. The insurances love to send us the EOBs and explain it to the patients. The insurances never want to explain it to the patients. So I mean, I
Where
would love to have an insurance executive on so we can talk to them and just really go through, like, how can we make this better for everybody?
I was
Because there's
gonna,
no way an insurance executive can sit there and say this is the best that they can do when they're part of the puzzle. There's no way that they can sit here
I'm
and tell me
surprised
that.
you don't have a connection with one, Jose. Maybe your dad
Um,
does.
I don't tend to, because I tend to speak a little bit too frankly with insurance people.
No, that's
So I've
fair.
gotten it. And so as I've moved and spoken to people and dealt with different insurance companies, they tend to not like me very much because I'm advocating for the provider or for a patient. So I end
Maybe
up
your
getting a
dad
little bit of
has one,
trouble.
has a connection.
I mean, I'm sure that if I looked, I probably
Be a
have a
fun one
Kevin
to bring
Bacon.
on.
Yeah, I probably have 6 degrees of separation with somebody, that we can talk to about this stuff. But I don't know though, So and that may be something that we need to look into.
Yeah,
But
that'd be
yeah,
a good
so
subject. We'll
yeah, that'd be
fireside
a fun
chat.
one.
We'll throw them in the fire. Throw them in the fire.
That would be a fun one. That would be a fun one. But yeah, so I mean, next week we got some. We actually this the rest of this month we've got some pretty interesting stuff.
Yeah, we're actually booked up until the first week of February, so I'm
Okay.
very happy to say we're ahead of the game. We're ahead of the game right now in 2025. It's been great. If anybody in this
Yeah.
chat, we always mention this for those that have been attending, but if you have any cool topics you'd like us to discuss, whether it's healthcare compliance related or at least something related to the healthcare industry, let us know. We would love to have a conversation about it. And it helps us fill our
Absolutely.
schedules up as well.
Yeah,
So,
absolutely. I mean, next week we've got Dr. Delgado
yep.
coming on. There were quite a few final rules that were passed very, very quietly at the end of last year regarding HIPAA. Um, Things are going to get interesting. And by that, I mean the changes are taking into account a lot of the breaches and where they're coming from and certain things. So you need to get ready for that stuff. There's a couple of things in there that you probably won't be surprised that are getting brought up and getting changed out, but there are a couple of things in there that sound extremely complex as well, but could be a little bit easier. Once you break it down to what are they actually asking for, right? Like they use all these big words. Like one of those, go ahead and just spell it right here. One of those is an organizational mapping for the IT.
Hmm.
So if you're running on a server or a VPN or anything like that, like how are the devices spidered together? Are they not spidered together at all? All that fun stuff. So part of that mapping is going to be something that's going on there.
Sounds like
Another piece of
a big change for IT companies that are managing those.
Well, it shouldn't be much of a change because you should have an inventory.
That's true. It's true. Well, if you're not
You
using
should have an active
EPICompliance, you might
inventory
not have
of
one.
Yeah, so if you don't have an active inventory, you don't have this. But if you do have an active inventory, having a map is just one more step that's really not that complex for most practices. Things will get interesting for those that are like doing imaging, or
Hmm.
you're playing with a bunch of different devices that then are reading and sending information back and forth, like a lot of the EKGs now. They can send stuff through Bluetooth straight to another device. So that's a device that needs to be protected. The EKG machine is a device that needs to be protected, plus the device that they're sending to. Or if you have an MRI or you're working out of a cath lab, like older systems are going to be a little bit trickier, but it really shouldn't be too much more heavy lifting than already having an inventory list. Because it's saying computer A speaks to computer B and it's off the hub that's known as computer alpha or
Right.
server alpha. And server alpha is hopefully not stored on site, but stored and backed up at a data center, or it's stored in the cloud. because we're using 365 or something like that, right? So mm, that's kind of that's kind of one of those things. So
Well,
we'll
it'll
we'll
be
talk more about it next week,
yeah,
and then
get
the
your
week after that we have what?
so the week after, that'd be the 28th, we'll be interviewing Rick Garcia. He's with Aroa Biosurgery, and I guess long story short, they do ECM technology for wound care, and he's going to talk about. He's been in the wound care industry for like somewhere between 10 and 15 years now. So just getting some perspective on the wound care and maybe a little bit of what kind of compliance is involved with that as well. And
Tracy, that might be an interesting one based on where you are and how many hikers you have up in your area. I mean, not this time of year, it's too bloody cold, but come summertime and everything.
they got some interesting products. I will say that much.
I'd be curious to see who can get certified to use it all,
I
all the
know,
stuff.
and I'm
Yep.
not sure. You know,
Yep.
that's why he's the expert, and we're going to ask him the questions. But from what I've read, it's like he's got some technology that's like these ECM uh, wound care, I guess, bandages or whatever you want to call them, are made from some sort of sheepskin, something, and it's supposed to recognize your skin, I guess, if you have a burn or
That's
I
too
don't
high
know.
techy for me, Ray.
It's some techie stuff, but he showed me some before and after pictures, and it's just crazy how much like a wearing this thing on like a burn for a week, it just like how fast it heals it. So
Got
I don't
it.
know.
So make sure
It'll
I
be
have
interesting.
lunch. Make sure I have lunch quite a bit beforehand because
Yeah,
I get
no, I
squeamish with
told
some of
him
this
to.
stuff,
We're gonna,
man.
or I told him when I spoke to. Well, I want him to show some, obviously some before and after photos. I was like, please, 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 don't go too far because I've seen some like extreme cases, um, like bedridden, like ulcer,
No,
just
no, no,
yeah,
no,
just
no,
crazy, crazy,
no.
crazy, crazy
There's a reason why I'm
situations.
on the admin side, Ray. Because I
Diabetic
would look,
patients
dude. I would
that.
look at one. I would make one look at that, and I'd be like, "Nah, we just need to set that whole thing on fire. Like we done here. I'm bye. Like I'm leaving. Somebody else
Well,
deal with this. I'll rock paper scissors it.
one of the co-founders of EPICompliance is an ER physician, so I've seen my fair share of photos from there. So
So
this
I
wasn't
don't know if
too
you remember
brutal.
this, Ray. There was one conference we did where we had an interventional radiologist. Really cool concept. And the stuff he was doing was awesome. Until I saw the pictures and I was like, I should not
Yeah,
have eaten lunch. And that was right after lunch. And I'm just like, oh, the timing on this is awful because I'm not gonna be able to sit right.
yeah, I've seen
So
some
yeah.
interesting things.
Yep.
It
So
just
we've got those
reinforces
two.
why I never became a physician. I
Yeah,
don't
right.
want to.
One of many reasons why I didn't go into the
God
clinical
bless.
side, right? So,
God bless
so
him
those are
though.
the next two, and I know that you and I were kicking around a couple concepts for after that. But if any, like I said, if anybody, and we always say, if you've got a topic that you want us to go into, we are more than happy to dive into that topic and again on the general side of things. But if you have some specific questions about specific to you and your practice, please let us know. And we're more than
Absolutely.
happy to talk to you and help guide everybody because we are completely selfish in our selfless ways, right? Like we want everybody to stay in business because it helps us stay in business, right? So please, 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 the more you know, the more dangerous you can be, but the more traps you can avoid, so please
Absolutely.
leverage the resources you've got available to you.
Well, Jose, I appreciate your time and everybody that joined us today. I appreciate your time as well. Just be on the lookout for some correspondence. You'll receive a link for next week's webinar session. It'll probably go out late afternoon today. So just be on the lookout for it. And then if you guys have any questions, concerns, please don't hesitate to reach out to us. As Jose mentioned, we're here to help. So, Jose, I appreciate your time.
Yeah, as
And
always, it's been fun. We'll see you guys next week.
looking forward to it and looking forward to having Dr. Delgado weigh in as well. That's always going to be a good conversation.
I mean, We'll try to keep HIPAA entertaining.
Yep.
So
Awesome.
have a good one, guys.
Thanks, Jose. Take care.
Bye.